thank you for joining. My name is Miriam Paramore, and I'm going to moderate our session today. I have been in healthcare and health information technology for almost 40 years. It's my 39th year. Some of the things that I've done that are relevant to our discussion today are I was one of the executives at a company called Indion, which is now Change Healthcare. Back prior to our IPO, about 10 years ago, I left there. I've been investing and running various sizes of health IT companies in the interim. I started out as a programmer a long time ago, and now work with Goldman Sachs and Sixth Street and private equity firms who are investing in growth stage health IT companies. One of the notable things I did that's additive to today's conversation is to create and launch what is now called the CAQA Index, which kind of helps us keep track of how we're doing with automated healthcare or digitized healthcare and exchange between payers and providers. We may reference that at some point today. So it's a real pleasure to be here and share with you guys about the passion that this topic that we're all passionate about. So it's my pleasure to introduce our panelists. We have with us first up, Alison Aluli-Imberman, who is Vice President of Operations at Health First Health Plan, and also Don Rucker, who is the Chief Strategy Officer at One Up Health, but also importantly is the immediate past Director of the Office of National Coordinator for Health IT. So we're going to get a fantastic sort of up close and detailed understanding of how a health plan, Health First Health Plan, and Alison in particular, are working through payer data and interoperability and clinical data opportunities and challenges. And then we're going to be able to talk about the same things on a national scale. So Alison, welcome. Would you start us off by telling the group a little bit more about yourself and your company?
Sure. Thank you for having me today. So I very similarly to you have a extensive background in healthcare and the healthcare industry in general. I've been in healthcare for a majority of my career, about 28 years or so, both on the payer as well as the service and clinical sides. A majority of that really on the payer side through multiple facets of operations, including and not only part of that, but data management, data integration, implementation, information technology. I also have a master's degree in health care informatics. And so data really has become a passion of mine as part of our healthcare continues to grow and seeing us evolve. So thank you for having me today.
Thanks, Alison. It's great to have you. Don, please tell us a little bit more about you. You've got such an extensive background and what some of the notable things you've done and then what you're doing right now.
Yeah, so I've been involved in healthcare. I can't tell you how long because it would violate HIPAA in terms of personally identifying information, but a long time. I think, the interesting thing is I got into the field for what we're talking about today, which is to make healthcare more efficient and more affordable and more reasonable. And that has become, initially it was EHRs, sort of a standalone product, but increasingly, especially as we talk about economic efficiency, it's become about how do we integrate clinical data and claims data. That was a big area when we were at ONC and allied agencies, National Center for Vital Health Statistics, our congressionally mandated high-tech advisory group, the work of CMS, really on how do we actually merge these data streams to do the type of purchasing of healthcare that we would like. And, part of that is APIs, a very large part of it. Part of it is policies and incentives. At One Up, we have a cloud-based platform that allows you to scalably integrate all of that data, convert it from whatever form, in many cases, not all, convert that into FHIR to maximize computability. And with most modern cloud platforms have a rich set of APIs. The APIs, of course, drive the CMS requirements for APIs, but that's really only the absolute start of what you can do. And I'm the Chief Strategy Officer.
Yeah, well, thank you. It's just a pleasure to be able to talk with both of you. We're gonna, for you guys that are listening in, welcome, and we appreciate you spending the time. We're gonna talk about these topics here, and we're gonna leave some time at the end, probably the last 10 plus minutes for Q&A. So kind of be thinking about some things that you'd like to ask our panelists while we are talking through these topics here. The first thing we want to talk about is just how complex this data world has become. When I started, we were really largely a paper world. We were still, in fact, even, I hate to say this dinosaur comment, but sending in claims still on paper. There was an awful lot of that. Providers were paid by payers with paper checks printed and mailed, in the mail, stamps and all. However, we've now sort of evolved into a fully kind of digital first world. And we have a lot of data in a lot of computers. So it's complex. And while that has happened with our digital transformation, we've had more and more and more regulatory demands mount up, and Dawn referenced a few of them. So we're just going to talk about kind of baseline of that. And then we're going to talk about the increased need for payer and provider collaboration, which just begs the question, if you're going to collaborate, you need to be able to exchange information, minimally exchange information, but even better, to really communicate and use the same data as the baseline for reporting, for decision-making, for reimbursement, for clinical care, and so forth. We're then going to talk a little bit about Health First's specific vision, how they're thinking about FHIR, but more beyond just the patient access use case. How do we actually make that strategic? And I put this phrase together, Alison, strategic operation, which may be a little bit different for people, but you're running operations, but it's important for you to operationalize strategically this investment in FHIR and data. And then finally, we'll wrap up with Dawn kind of talking us through, given what we've learned from Health First, what are we learning, kind of industry-wide. So just wanted to lay out for everybody on the phone kind of the outline, and we'll make this a very interactive conversation. So everybody just jump in. And but I'll start, maybe Dawn, just start with you to kind of lay the groundwork of how you see the complexity of both, data acquisition in a world of, quote, interoperability while meeting regulatory demands. And then Alison will take it to you and kind of talk about our 2026, runway. So Dawn, you want to kick us off quickly?
Yeah, Miriam, I think, the interesting thing is, as you look at the timeline of what has become computable, that gives you a lot of insights here. So if you look at that, the first thing that really became computable in the 80s were lab results. All the automated clinical analyzers, went from handwritten lab results on little things you glued into paper charts, like shingles on the side of a house, to the HL7 version 2 data. Somewhat after that came HL7 ADT feeds, right? So simple, like tabbed eliminated data structures. And that was what it was clinically. I think the big kahuna on some level was the mid-90s, 96 HIPAA, which got X12. So we finally had computable claims, and HIPAA basically required payers and providers to submit claims electronically. This was, frankly, a huge win for providers, because when we mailed in our claims, when we would get paid was, typically mañana, which could be really long. And of course, almost unauditable. And then as a side thing, which we're not really going to talk about today, the other big data acquisition actually by far the biggest in bits and bytes on provider side are images and DICOM. And that the forcing function there was CT scans started digitally generating so many slices that you couldn't hang film on alternators, those light boxes that, people would sort of scroll. Maybe now you sort of see it in an old movie or something. When you look at all of that, of course, there was something missing. In the middle of all of that, what was missing? Well, what was missing was computing about clinical care, right? That was like
taking care of the patient.
Yeah, the care of the patient. That was the thing that was missing. And there have really been two stabs at that. One that was not fully successful, and one that I think is what we're talking about today. The first stab was HL7v3, so version 3. And that was this elaborate XML architecture of patients and services and providers. It was blisteringly complex, and it didn't even fly as far as, Howard Hughes' Spruce Goose, which was that big plywood airplane that I think made it a couple hundred yards. What was left out of that, right? So out of the ash of that were CCDA, so clinical document architecture documents, but without all of the rest of the computable surround or non-computable surround. And then the sort of inner kernel of that are the continuity of care documents, the CCDs. That was sort of what was left of the first part of it. People looked at that and realized, okay, this is reasonable, but this doesn't really make for ready computing, right? Because it's not field level data. So this is like the 1990s page view document architecture. For those of you of a certain age, you looked at Yahoo or AOL and you got a page. And then you had folks like Jeff Bezos and, jQuery and React and Angular moving in these programming paradigms where you could compute on fields. We did not have the ability to compute on individual fields in clinical care until FHIR, which leveraged the rest of the internet. So the JSON data structure, the RESTful APIs, technical terms you can Google. And that's really the power of where
we are right now.
Where we are right now.
That's a great.
Yeah, and the federal policies have obviously tried to push that all along. But hopefully that gives people a sense of the inner nature of the data we're talking about.
That's very helpful to give us a groundwork for now that we have all that. And Alison, can you comment on sort of your experience in kind of going through those waves? Because all of that stuff is probably in your world, further creating, this complexity. Tell us about the complexity in your experience.
Oh, absolutely. Don really hit on the history of what we've tried to really evolve past, I think, in healthcare, and being able to gain information that really not only allows us to be able to treat the whole member, the whole patient, but to also be able to access data that previously wasn't accessible. And to be able to really allow ourselves to be able to exchange that amongst caregivers along the entire continuum. And so that has definitely been, I think that summarizes for sure the challenge that we've had in healthcare in general, and what we are trying to now get beyond.
And I liked this concept that you have, Alison, of sort of layering on. That it's not that we're taking out anything that Dawn just mentioned. So in my view, no one on the phone or in the industry is going to rip out the infrastructure of the revenue cycle of healthcare, which is based on X12 transactions, and say we're just going to redo all that. I don't think that's going to happen. So it's a layer underneath some of this stuff, but it's critical driver of the claims-based data, as an example. But how are you thinking about this layering on with respect to some of the key upcoming deadlines of 2026? How do you see that?
So I kind of see us in sort of like, if I look at this from a super high level, in sort of three phases. If I were to have to explain this to somebody who really didn't have any familiarity with where we're going or where we've been, I see ourselves sort of today we're in sort of phase one of creating a foundation. This isn't a one-time thing where we're just going to put a stake in the sand and we've reached the end of the journey. It's really an evolution of being able to continue to get us to a better place in data acquisition and utilization. And that's partly goes to what Dawn was saying, was being able to add elements or functionality to the data as we continue to evolve. And then I think the second phase is increasing our, within the healthcare industry, to increase our data literacy, being able to increase the knowledge that our operational leaders and really anybody who's in healthcare, with being able to utilize the data that they have access to and make that data more readily available to everybody.
Yeah.
And then I think the third phase, really from my perspective, is really infusing our operations with interoperability, being able to share data amongst the full continuum of care allows for us to be able to, and as I was saying at the beginning, to care for the whole patient, the whole member, and to be able to see that. So that's where I kind of see us going at this point, where we're at in our journey.
I love that. So kind of three phases, just to kind of recap that for everybody that's listening. We've got this foundational layer, and we're building upon this foundational layer of data acquisition, and I don't know, data, not just acquiring it, but putting it somewhere where it's computable, to Dawn's point, right? Data acquisition and hosting and harvesting and organizing, that sort of thing.
Sure.
Secondly, the data literacy layer, where everybody who is working for the benefit of the patient/member, right, knows what is this data, and can we not only speak the same technical language, to Don's point, but also can we, as business people and lay people and humans, patients and caregivers, know what it is we have in this treasure, so that we can make great choices out of the data. And then finally, it's really that third layer is just getting to sort of operational excellence or operational improvement. Did I capture that?
Exactly.
Well,
it's exactly, our ability to be able to get to the point where we can actually use data, analyze it. We have the skill set to be able to analyze it, and in a positive way, really leverage it for the betterment of not only us as caregivers or healthcare workers, but also for obviously the patient.
Okay, well, I appreciate that. Dawn, in response to that sort of thinking and construct, can you talk a little bit about the regulatory demands that are coming down the pike in 2026, and perhaps how those, X12 plus HL7 plus FHIR have us, sort of all layering on? What are we layering on in 2026 that people need to be ready for?
Yeah, I think I think we can start with the big picture here, which is American healthcare doesn't really work.
Right.
I mean, let's be real.
Yeah.
It's extraordinarily expensive. It's a often very poor consumer experience. Sometimes it's great, but a large number of times it's not. And we don't have a public who are happy with healthcare or the amount of the GDP we're spending on it. Mm-hmm. So I think when you look at the macro, what you're seeing is constant policies to really make healthcare somehow more efficient. And as you might imagine, this kitchen has members of Congress as one set of cooks, CMS and the other agencies is another set of cooks, and then a bunch of healthcare economists and policy people throwing various food groups into the kitchen from outside the door.
A great analogy.
And then people have to figure out, oh my God, what do I do? Right. So it's not like very simple. And I mean, just in the last couple months, we've seen tremendous noise on how much we're paying Medicare Advantage plans or overpaying them on some level.
Lots of noise there.
A lot of noise, and prior auth denials and all kinds of stuff. So if you look at that environment, I think what is clear to me is that maybe not explicitly, but certainly implicitly, Congress and the agencies are pushing more and more of the burden of allocating care, of rationalizing care on this combination of payers and providers. They've given up on letting the providers police themselves. They just have, when you look at it. And so what does that combo world look like? It's things like prior authorization, it's quality measurement, it's network design, it's access policies. And of course, then the surround, care management, sort of the continuum of care, not just going to your doctor and in this every 6 months. And in this digital world, we have, of course, vast opportunities to do healthcare outside of the classic things that generate an X12 claim.
Right.
So when you look at that, at the heart of all of those computable things, every time people look at it, is data, right? Every law that Congress has passed that I'm familiar with in the last couple of years has had a data reporting requirement. The upcoming prior auth stuff will have a data reporting requirement in it, whether that's both in the bills in Congress or in the proposed rules in CMS. And then all of these things basically are, let's have the APIs to actually make these data conversations doable. If you don't have an API that allows you to communicate and share, it's sort of vacuous. And, folks have tried stuff early on with ACO and rosters, but in this modern digital world, they're really, first and foremost, Fire-based APIs with RESTful transformations. And that's what the policies are driving to. And they're fairly explicit, right? I mean, they say, what the API is, what the features are, if it's Karen Alliance or Da Vinci, and, OAuth 2, those are the way that we're going to get to these richer value conversations.
So kind of building on that, because you said a lot there, and I often forget. No, it's good. I often forget how much I know and how much we know, because if you were just like somebody from, I don't know, real estate listening to this phone call, you'd have no idea what all of those acronyms, sort of mean. And so, but then I think when we do our day job, Alison, I'll kick it back to you, and you think about prior authorizations. We were talking about this yesterday. There's an X12 prior authorization format, and it was assumed that everybody understands that things are better if they're like in a computer than on paper. And so that data exchange would be better than the mail and fax. So let's do that. And so we didn't do it. The CAQA index would show you it's just an abysmal adoption rate for things like prior auth and OPS. That was 30 years ago. So like there's better computing right now. So when you think about this layering on and your own payer provider collaboration at Health First, let's talk about prior auth. How do you see that? That's one of the 2026 things. How do you see tackling that as an organization? What's that look like for you?
Yeah, and I definitely feel that prior authorization has been in the last, several decades, something that was seen as a requirement of us being able to improve the cost of healthcare, right? To be able to control those costs within a data stream and within the operations. Prior authorization and including it now in interoperability with a looming 1/1/26 date, it definitely is something that I feel starts to bring the full picture together. It brings all of the data into a sort of a single stream so that we have the visibility for a full continuum. And it allows for us to, again, be able to see the full member and what care we're giving them. And that I definitely feel that this is in our evolution is one of the next steps that's required for us to be able to get to full interoperability.
When you look at that with respect to your own, and we can come back to quality measures if we want to, if we have time. But when you think about prior auth with respect to your own sort of investment in FHIR, and I'm kind of moving into this, health first vision. So feel free to elaborate and take it off of any way you want to. But how are you seeing the current capabilities that you have around data? And then, we've all had to invest in FHIR, given, some of the mandates. And Dawn, you made an excellent point. I just want to throw that back to you, Alison. That point was every time there's a legislative and then a regulatory follow-up, and that regulatory says thou must do something, it also puts in a reporting requirement about the thing that thou must do. Right. So we've just got more and more report cards to create. So, Alison, tell me more about FHIR with respect to a layer that kind of helps you do prior auth as you're thinking about it.
So I feel in the industry in a whole, we're still at a place where we need to mature our data acquisition and accessibility in order to be able to appropriately utilize and leverage FHIR for the future. I still feel that the industry is catching up a little bit. To Dawn's point, there are those are regulations that are put upon healthcare to be able to increase perhaps the cost of healthcare across the board, as well as the efficiency, but it takes time for us to be able to continue to evolve what we've previously acquired, as well as where we want to go to in the future. And so I still feel that there's, in general, some maturity that is required, which is why we come to a company like OneUp. We want you to utilize and leverage the things that you have gained maturity in order to be able to, again, help ourselves gain some maturity within our organization. And so I feel that while we are starting to evolve to these additional factors, such as prior authorization, as well as the provider API and things like that are coming in 26, we have a runway right now. We have a time period in which we know these things are coming, but we have the ability to, as I was saying previously, to mature our organization, our associates, ourselves, to a better data literacy to be able to prepare for those things that are coming, but also to be able to utilize those in a positive way once 26 comes, to be able to see where we might be able to infuse those again into our operations and not just wait for the deadline to come.
Yeah, exactly. There's an awful lot of kicking of cans in my experience. So Dawn, I want to take that back to you for a minute and go a little bit into best practices. When you because you're looking across the whole country as the leader of ONC, immediate past leader of that, and then you still have a very, very broad strategic view. What are some of the best practices? How would you say sort of everybody's still catching up? How would you gauge kind of where people are and what's the best sort of next step that people are taking in this FHIR evolution?
Yeah, I think, maybe the first step, certainly if you're a payer or, a provider, depending on where you are, the provider is a little bit different, right? Because you have an EHR. So presumably you're going to be anchored in the EHR. Just inertially, it's probably a big issue for provider efficiency when you get right down to it, because our current generation of EHRs essentially have zero automation in them. That's a side note.
That's an interesting comment that our current EHRs have no automation in them.
Right. Computers everywhere and automation nowhere.
Nowhere. I love it.
That's after the prior federal policies on, documentation for payment. I think if you take more of a payer side look to this, the big picture, I think, is you're going to have to understand the patient clinically. And historically, the way payers have understood patients clinically is to try to infer data from the claims, right? So you had
The
this
diagnosis and the claim, or the procedure, the diagnosis plus
exactly.
the combo. Yeah, and go backwards.
Exactly.
Yeah.
Go backwards. That's what it was, not just on payers, but in fact, almost all health services research, as a side note. Interestingly, you pick up an issue of health affairs because they couldn't get at the data any other way. They would try to go backwards and infer. That's not
pull charts, right? Send people out to run around and pull charts.
Or yeah, that was
charts. Yeah.
Right. That's sort of it's if it's really dire, your HEDIS score, you'll pull charts. But I think the future is really, how do you get enough clinical data to make reasonable clinical judgments about the allocation of care, right? That's what prior auth ultimately is about. The reason it failed as an X12 transaction is, as you perfectly well know, is because the X12 prior auth transactions are empty vessels with no structure and no real data in them. So you can't share clinical information. And so people had to share clinical information with, faxes, PDFs, questionnaires, phone calls, multiple phone calls, more phone calls, type of thing. But in the modern world, payers are going to have to get, which they have a legal right to under treatment payment operations, get more clinical data on patients and compute on the actual clinical picture and not just the shadow of the clinical picture left in the claims trail. That's interesting. That's what the world is going to have to come to. Some of the, without spilling proprietary beans, some large payers have actually been building virtual shadow EHRs. But, that's a pretty daunting thing to do if you're, without some sort of help, and it's sort of not the best use of resources as a payer. I would argue that's obviously a one-up health-centric argument, but, people can take it as they wish. But one way or the other, you're going to have computable clinical knowledge and platforms where you can make what are intrinsically and inexorably clinical decisions, whether it's to give somebody an expensive monoclonal antibody or extra days in the hospital or triage between surgical and non-surgical approaches or send out case management or provide SDOH services. You cannot do that anymore in this modern world with just claims data alone. So I think that the platform that one has to build, you have to figure out what are my capabilities. And then it gets into all of the highly mundane things like, how do I do, the member IDs and, how to set up the FHIR resources.
Patient identifiers.
What tools do I have? What analytics am I going to use? All of that blocking and tackling, as well as, to Alison's point, who in a payer world is actually going to use this, right? It's one thing to have a data platform that you've munged with APIs, but you have to have an entire business strategy. Who's looking at the data? How are they looking at the data? What's the whole, Maslow hierarchy of needs type of prioritization of looking at these clinical data stores? Now, the Maslow hierarchy of needs will probably in part be done by Congress and CMS, as always.
There's sort of that have to. And, how do you think about that, Alison? I'd like to kind of combine these concepts you've shared about data literacy with your own, running a company called Health First Health Plan, that, you're running a business. And so you'd like to be able to have fantastic patient outcomes at appropriate to lower cost, which our industry has not been able to do. Our industry has not been able to improve outcomes while lowering costs, period, to Don's earlier point. However, that we're all still passionate about the role of data to kind of do that. And Health First wants to do well as a business. So
Sure.
yeah, so what is hard? What is it that's really hard today about this clinical data exchange and infrastructure? Is it alignment? Is it tools? Is it I just want something that helps my own business process? Talk to me about that.
So I think it's all of what you've just said. It is partly the tools, the multitude of information that we try to pass between the tools that we use to run our operations. But I think it also is, and Don was talking about this sort of a decision-making hierarchy in the clinical care of a person. And I do feel that there is, on the payer side, I would agree with Don that there seems to be a sort of a backing into getting to what a patient may need out of, in some ways, very disparate data. And so to really bring FHIR to the forefront and to be able to start to see data, see clinical data on the payer side, I feel is going to make our operations in the end more efficient.
Yeah.
And to answer your question, I think what we're challenged with today is to be able to bridge the gap between where we are today in our healthcare processes, which I think Don is kind of explaining this has explained this as being very flat. We don't have the multi-dimensions of what it is to care for a patient. And that's where FHIR comes in. We start to be able to see the multi-dimensional care from a different perspective. Today, it's very flat. So to bridge the gap between where we are today to where we want to get with FHIR, that's the challenge. Our tools need to be upgraded and changed and thought of in different ways. We need to be able to create data stores that are accessible to not only those of us who are passionate about data, but also to just the general population that needs information. They need to be able to access that information to, as a patient, to be able to take a little more control over their own care, a provider to be able to care for that patient, and then a payer to be able to help to make the care from a financial perspective more efficient.
Right.
And so this bridging of the gap, that's the challenge. That's the challenge at this point.
I think that's sorry, I didn't mean to cut off the end of your sentence there. There's a tiny bit of a delay, always in these audio things. That in my experience, in my career, there's been one of the elements of inertia, to use Don's word from earlier, is simply the switching cost of however it is that the business process works today on an incumbent data store, which is from some vendor that was, Trizetto or somebody from, 5,000 years ago, and the way, facets and the way they organize things for claims versus, let's say, Epic or Cerner on the EHR side, how they organize things for clinical or charts for billing. And then not to mention the world of images and things that you talked about before, Dawn, which are also digital, but in another silo. So in a health plan, it's not uncommon for you to have multiple claims adjudication systems, Allison, and perhaps you have another system for utilization management or population health management. Is that's still kind of how it is? You've got lots of systems that you've purchased from multiple vendors. They have data stores underneath them. And then, Dawn, you're talking about sort of, it's not really an inbound stream. That's not the right way to say it, but using FHIR and APIs, where does the information go? Like the new clinical information that's coming in, and then the payer has all this old stuff. Where does it go in this perfect world of that we're trying to get to, of a new repository? Allison said, let's have a repository where we're all literate about what's in there. and let's have a repository where you can actually get to it computably, which is FHIR. And then let's have a repository about how that we know what's in there. So how do you see that actually work on the ground, or across the country, Don, with people ingesting? Where does it go? How does it help a health plan that has all this old stuff?
I think the first thing is, right now you got to look at what's actually standardized, right? The data that's not standardized, you're not really going to
help you, right?
Except in text, right? Which we know. So the stuff that's standardized, obviously the X12 is standardized, so that's powerful. The US core data for interoperability, so that's med lists, problem lists, allergies, some provenance, and blobs of text, that's what's standardized in current rulemaking and current certified EHR requirements. The CMS APIs basically riff off of those things. So I think you start with the things you have standardized, and see what you can make of that. The Cures Act actually required all data to be defined, exposed, by an API, but there were no standards. So, it was we just did it as, with a vocabulary label, and how that'll play out as sort of more of an AI type of or natural language processing. The work of Da Vinci on prior authorization is essentially putting that into FHIR is really the next wave of standardization. So you can see as FHIR spreads, because of its essential elemental simplicity, JSON data structures are just, you can open it up in your word processor and understand what's going on. As that spreads, you're going to see, and we're already starting to see, the richer use cases. Prior auth, NCQA has a major effort to move all of the HEDIS analytics into FHIR. So that's where you're seeing this whole industry move. And they're obviously driven by the big financial use cases, which, prior auth, quality of measurement, those types of things. And I think also we'll see more stuff on consumer convenience, right? Whether that's appointment scheduling or, getting data under, your control on apps so you can shop, so you can integrate with your devices. That, there's a side note, is the current battle around TEFCA. Some of the incumbents in the field don't want to let apps get at the data. They want to hide it all QHINs. But, the modern world, I hope, will win out on that. We have that control in our phones. But that's how the computability is moving.
Well, that's really interesting. And I'd love to give Alison, you a chance to sort of respond to that. Does that make sense in the way that you think about it? Nuance that a little bit more for us from your point of view, and then we'll open it up for questions.
It does. I mean, definitely X12 was, again, one of those foundational steps that has gotten us to the further evolution with FHIR. And the acquisition of data, being able to use it, as Dawn is saying, is computable, is a place and is in a structure that allows for us to be able to report off of it, to be able to analyze it, to be able to then take it into the care setting and or for a next steps in in an operation. It most definitely is this is going to be what we have to solve for in the future as an organization, and even in operations, to be able to evolve where we're going with FHIR, and being able to utilize data in a different way. It's a challenge we're still trying to solve for.
One of the things I love about this conversation is, neither one of you are coming at this from an IT perspective, I'm probably the nerdiest person here in that regard, given that my first job out of college was as a programmer for HCA, and my degree's in math and computer science. So like I used to write code. But what I think is so powerful about it, and the way I think about it now as we go into these questions, is this isn't a technology problem. This is not an IT budget problem. This is a business transformation opportunity around all of the computing power and all of the data that's available. And so I love it that you have an operational hat on, Alison, as you think about it.
But I will say technology is a huge facet of what we will obviously need to have in the future. It will allow for us to, I think it will be a good portion of the solution for how we're going to solve for this in the future. Yeah. And most definitely will partner with many parts of the data infrastructure and architecture and all of those things. It will definitely be part of the solution.
Yeah, and it's, we live in a data first digital world now. Data, we really are a data first world. So I love this question. Our questions are starting to come in. Please submit your questions on the Q&A. Here's the first one. The value of clinical data to payers is pretty clear. The challenge is the parenthetical apparent lack of motivation by providers. Can you speak to what should be motivating providers to be part of the data exchange? Let's start that off with you, Alison. What's in it for providers?
So I honestly feel that with this 1/1/26 deadline coming up, I think their motivation should be, this is again speaking from my perspective, is the fact that they can see the whole patient, the whole member, and for them to gain access to all of the facets of care for a member or patient should give them better visibility to the data that helps them care. And so from my perspective, I would say that, this is speaking from an operations person, not a clinician, but from an operational perspective, that it allows for them to have the full picture rather than just parts and pieces.
Yeah, and to take, you might give us the clinical view. You're a clinician, Dawn. You play one on TV. It makes sense that if you are a specialist and you know what you've done to and with that patient, but you don't know what anyone else has done to and with that patient from your clinical view, whereas the payer might have that more holistic picture to kind of share back as sort of that continuity of care, that longitudinal record. What's in it for providers, Dawn? How do we get past that motivation?
Yeah. I think the points that have just been made are absolutely true, right? As an individual provider, you may or may not have a broad picture of the patient's care. If they're all in your institution, you likely will. But if, as most patients do, shop, move, go about their business in various ways, you won't have that. So payers are really the unique source of that data. They just are in the American healthcare system. I think the other thing here, now I'll really put the provider hat on, is providers aren't going to share the data until they have economic incentives to do it. Let's be real here. Payers and providers, especially payers, have to get together and make this a net win for providers to share. Payers have legal access to the data as under HIPAA, right? They're covered entities. Providers are covered entities. You can use a business associate, but ultimately for treatment payment operations, payers have access to the data, but I think they haven't really made win-win incentives for providers to go through what probably not a lot of effort these days since it's all in a computer, but some effort. And you have to write contracts where the providers aren't scared because they think all of this will be used to negotiate against them.
Yes.
Right? That's the real issue here is if I'm a provider and I'm giving payers info, it's like they'll use that to negotiate against me. So I think we have to be far better at how we do risk sharing in these contracts and how we have continuity over time. A big problem in American healthcare is many of our insurance contracts are year to year,
That's huge.
based insurance. And so nobody has an incentive for prevention, continuous care, because in 2 years the patient's going to be on some other plan. So you're not going to prevent their heart attack or stroke, because ultimately, not that you would ever say that, but somehow intuitively it'll dawn into your brain, that's downstream. So I think we have to be smarter about contracts to
It's a great point. And that type of thing is an underlayer here that we're really not discussing today. And I'd love to have that conversation, Alison, with you as I love to have a whole other talk just about contracting, and then measurement on top of contracting. Even the HEDIS stuff, I was looking at a payer's instructions to providers for sharing the information required for HEDIS. And it was like a 27-page PDF. And it had inside that PDF, it had, here's the 6 different ways you can send us the data. There's like Excel, carrier pigeon, email it to me in a Word document. I mean, it was just, I'm thinking this is current. Like, I've double checked the date, like, oh yeah. So, HEDIS contracting, accountable care, shared risk, whatever you want to call it, does motivate provider organizations to share data if they're participating in whatever it is gets scored, right, Alison? But otherwise, you're not, you're lacking some of that motivation, which we can't solve for in today's call. Yeah. But I do have a different question that's come in, and I don't know if you guys have experience, but the question is, what experience do we have with Epic Payer? And what do we think about it? So Epic Payer, for those who don't know, everybody knows who Epic, the EHR company, is, but they have created, it's been a few years back now, a payer experience or module or a component where payers are able to access, I think somewhat directly through that module, the EHR record of their members. Alison, do you have any experience with that platform?
I don't have experience with Epic. I know a little bit about the payer platform, Tapestry, a little bit on that side. It is not a tool that we use within our organization today.
Okay. Don, have you heard anecdotally or?
Well, my understanding of Epic Payer is that they're basically providing an Epic view of the world that, as with all things Epic, great cost. I think if you really want to manage care, you got to get the data into your own paws. I mean, it's sort of a fairly basic concept. There's some convenience in that, but if you really want to do analytics and power modern APIs, I mean, the problem, and it's obviously great for Epic, it's a closed platform. It doesn't, as I mentioned before, it has no availability of computing and providing intrinsically efficient care. It has no real ability to innovate in the delivery of care, right? Having a patient portal in my chart is not exactly the consumer experience we have in any other app on our smartphone, right? You can look at the delta there on pick your favorite 10 apps and ask yourself, what do I get here? And so, kudos to Judy Faulkner for building, a dominant product, but it really has almost nothing to do with where we need to go in modern healthcare. It's a very provider-centric, chart-centric view of the world. It's not an automation, maintenance of and improvement of healthcare as living human beings view of the world. The payer portal obviously is a peephole into their underlying view, but in and of itself is more of a prevention of modern computing than anything else. Obviously there's convenience, there's shrink wrapped. So yeah, pick your poison.
And it's out there, but to your point, that it's an Epic centric, so whatever provider is on Epic, and maybe a lot of providers are, but it's Epic centric and sort of episodic, centric too. Whereas I think, Alison, our goal that I'm hearing you say, and this is kind of wrap up in our last few minutes, any closing remarks, is really getting this data, I'll use data liquidity. So we've got data liquidity flowing into the health first world, but then you're also using the computability of FHIR as a baseline, as part of your tapestry, to use that word. Any closing thoughts on that, or things you'd like to share with the group?
I think we all have to be open to the fact that in this evolution, we have the ability we have access to information. It's how we use that information. And as we start to increase the accessibility through FHIR, it's how we allow that data to become part of our decision making, our growth of the future for healthcare. We have to look at it from a different perspective. And I think from my perspective as a leader, I want to be able to leverage that in a positive way. And I think that, FHIR and the future of the direction of this data access is a good step in the right direction.
Yeah, thank you. That's great. I really appreciate your insights. Dawn, any closing remarks for our group?
Yeah, I think these are exciting times. We've, as mentioned, have all sort of seen this evolution. I'm extraordinarily excited that we have the components in place today to allow a patient-centric compute environment to be built where we can monitor our care, continuously. Think of your Apple Watch or your Fitbit or whatever. Think of what healthcare in the future is going to be like. I mean, don't forget, most of the things that ail us and kill us are actually largely preventable. Almost all vascular disease today, if you're digitally smart, is preventable with things like cardiac CT angiography, statins, all of these meds, exercise. Cancer is probably on the cusp of being largely preventable when you look at circulating tumor cells and, combined with modern imaging. So we're almost at the cusp of harvesting the innate power of all of these digitally enabled technologies, whether it's circulating tumor cells or imaging, or drug design with computers, to give us a really much healthier life in the future. And it's exciting. And I think FHIR is one of those key building blocks. The cloud networks are, is the other key building block to build on, what we've already built in EHRs and things like X12.
Yeah, I agree. I really have enjoyed this conversation. I still am excited after all this time about the power of information in our industry. I appreciate it so much. Thank you, Alison, and thank you from Health First perspective for being willing to share with us. And Dawn, thank you very much. And if you have follow-up questions as you think about and digest this information we have up on the screen here, please reach out, just shoot an email to info@oneup.health. Thank you, everybody. Have a great rest of your day.